Violence in clinical settings is a significant and growing problem. These graphs here are from the Bureau of Labor Statistics, and they show the trends from 2011 through 2018. On the left, we can see that the majority of non-fatal workplace violence occurred in the healthcare industry, which is represented in red, compared to other industries shown in blue. According to the BLS, healthcare workers experience 73% of workplace injuries resulting from violence. On the right, we see that the incidence rate per 10,000 full-time workers increased and in fact nearly doubled between 2011 and 2018. And this is before the pandemic. Unfortunately, we also know that workplace violence in healthcare is vastly underreported. Some estimates are that 70% or even higher of violent incidents go unreported. Healthcare has some unique cultural factors that may contribute to this problem. For example, caregivers feel professional and ethical duty to do no harm. We tend to be more selfless and are sometimes willing to put ourselves at risk in order to care for a colleague or a patient. Unfortunately, there's also this common misperception that violence in healthcare is just part of the job. Healthcare workers also recognize that many injuries caused by patients are unintentional, and so they're perceived as unavoidable. And another consideration is that we may be unwilling to stigmatize our patients based on impairment or illness. Sadly, though, fear of retaliation is also a major deterrent. So I mentioned that these statistics are from before the pandemic. And healthcare has been evolving in some ways that already increase the risks and the challenges. So, for example, reduced funding for mental health services means that patients who would have benefited from specialized services are now seeking care in other areas, including ambulatory, emergency departments, and the like. And then recently during the pandemic, there was an increase in disorderly and violent conduct across different work settings and public settings, and unfortunately, healthcare was no exception. Patients are the largest source of healthcare violence, but they're not the only one. Families, coworkers, visitors, or even intruders can perpetrate violence as well. So in light of these general trends and challenges, how do we approach prevention? We're going to use a conceptual framework as a foundation. This conceptual framework is a 4-level social ecological model that was originally developed by Dahlberg and Krug in 2002.
In 2017, Press-Ganey released the Assaults on Nursing Personnel Indicator to inpatient, psych, perioperative, and emergency services. In the first 4 quarters, nearly 7,000 assaults on nursing personnel were reported to NDNQI. When I broke that down, that came out to be about 19 assaults per day. And when I shared this with my colleague, Mary Jo Ossie, the Associate CNO at Press-Ganey, she called it a chilling statistic, and I have to agree with her. I thought I would break down for our most recent data available of Q4 2021 for the adult, perioperative, and emergency services, and excludes the neonatal, pediatric, rehab, and psych unit types. So I want you to guess the number of assaults per hour. Okay, you guys ready? Over 5,000 in 1 quarter, over 1,600 per month, 53 per day. That comes out to be over 2 per hour. So in the course of this conference session, at least 2 of our nursing colleagues will experience an assault, and at least 1 will be injured. It's pretty chilling, right? How many of you had thought it'd be around 2 to 3 per hour? Raise your hand. How many of you thought it would be more than 4 per hour? Well, we're all correct because this data is not representative of all facilities. It's based on about 300 facilities of the nearly 6,000 acute care facilities in the United States. Plus, we know that assaults are underreported. Some research has shown that only 30% of incidents are reported because it's part of my job. They don't understand what's classified as violence. Some don't view it as a reportable incident. there's no sign of injury, fear of retribution, or the feeling that nothing will be done about it. And that breaks my heart. But that's why we're here, to share information so that you can go back and help take action. We wanted to look at the trends over time, and we calculated the assaults on nursing personnel per 1,000 nursing care hours. Nursing care hours is a good exposure variable because nurses are taking care of patients, they're interacting with other healthcare colleagues and visitors, and with any of these people being the assailant. The graph on the left is telling us several things. One, that assaults in the perioperative setting is the lowest, and that emergency services is the highest. Was anyone surprised by that? Rates per 1,000 nursing care hours is fairly small. There are less than 0.25 per 1,000 nursing care hours, or to put it differently, less than 2 per 10,000 nursing care hours.
So why develop an Ambulatory Falls Committee? You know, our experience was that, and I'm sure with all in this room, there is a big difference between inpatient and outpatient. I see some shaking heads in the audience, so thank you for that. Went to the literature and really found that there is really not much there in what we can do to help our patients in the outpatient setting and even in home care, because there is collaboration, as you'll see as I move on. But really transitioning, a lot of our patients are transitioning more to ambulatory services. There are sicker patients, aging population. So really the support is really wanting to provide patient safety and quality to really make sure that we do everything that we can to do that. Ambulatory volume, as you see, one of the reasons, as you saw the numbers that I just showed you on the graph before, really with the large number of patients we see every day, the number of falls that we could potentially have or have really is high or can be high. And then we were seeing somewhat of an increase in falls in the practices. You know, this does include employees, our caregivers. It includes all of our patients. It does also include falling in the parking lot. And in Ohio, as those who have not been to Ohio, we do get snow, just saying. So, you know, it's something that we needed to look at, and we believe that it was the right thing to do. So we're gonna look at this slide, and I'm gonna start with the inpatient. So we have your falls risk screening that you do on the inpatient side. Patient comes in, you ask them your questions. Bed alarms, you know, that are as fancy and as not fancy as you'd like. Patient education, you know, we have many things developed on the inpatient side for patient education, and our absolute favorite, yellow socks. Yes, yes. And door alerts, you know, putting something on the door to make sure that, you know, we know that patients are a risk for falls. On the ambulatory side, on the flip side, we have the MIPS question, and I'll go into per MIPS, per CMS. The MIPS measure includes, for those that do not know, the MIPS measure includes asking those patients ages 65 years and older with a visit in the measurement period, which really is the calendar year, and asking the risk screening question, have you fallen in the last 6 months? And then, of course, documenting it. Can't forget that, because if you didn't document it, you didn't do it.